Well, welcome everyone to this edition of the Bulletin Brief, where we're reviewing articles that are written by the Resident and Associate Society on the August edition of the Bulletin of the American College of Surgeons. And today I have with me Dr. Ochoa. And Dr. Ochoa is an assistant professor of surgery at the University of Florida, Jacksonville. And I'm really excited to speak to Dr. Ochoa today, because she'll be really discussing advocacy and about advocacy education. How do we learn how to become good advocates? What resources are there for advocacy? And how to learn about some of the major topics associated with advocacy. Dr. Ochoa, how did you come to a decision on picking this topic for your Bulletin article?
It actually came from really my own involvement within the American College of Surgeons. I was lucky enough to be more involved with the college early on in my residency, kind of going through all of the different programs that ACS has to offer and being very involved in RAS. I just became knowledgeable about a lot of different aspects of surgery that you wouldn't really get otherwise. ACS has a lot of different leadership opportunities and advocacy opportunities within their programming, such as a Leadership and Advocacy Summit, residents as teachers and leaders, and being a part of all those things got me a lot more interested in learning more about what is affecting surgical education now and what's affecting surgeons as a whole. I think what's really important too is, coming back to my program and being able to discuss, everything I learned with my program. It is really interesting how a lot of people don't really know what's going on. And it is really important for us to educate our fellow surgeons about what we are going to be facing in the future and what are the problems that we need to address to be able to be successful, not only in training the future surgeons, but also just supporting all of us surgeons as a community.
You discussed a lot of really interesting points in your article that I wanted us to touch on. One of them was really about the surgery as a profession and how we self-regulate. And one of the ways we self-regulate is our educational process. Could you describe a little bit what you learned about how the educational process is self-regulated within surgery?
The American College of Surgeons is a very old institution, and the American Board of Surgery is the self-regulating body of surgeons that helps in credentialing surgeons. It's been around for a really long time, since the 1930s. And the way that we kind of gain having the board certified status has changed the last few decades. And of course, there's a few bumps in the roads, especially with COVID and some issues in terms of being able to adequately provide the proper certification needed for board certification during that time to surgeons applying. I think that they have been a really great organization to really kind of change to what are the needs of the community to be able to hold up the integrity of surgeons being board certified and the process. Most recently, within the last few years, they've changed the way that the credentialing occurs. It is more frequent now than it used to be, having to update in a 2-year process versus a 10-year process. But at the same time, you're able to focus on certain aspects with surgery that you mainly deal with in your practice. And I think that's a nice way to be able to really kind of gear towards surgeons who have been out of practice for a long time and they really kind of focus on one thing, but also keeping up with the core foundations of surgery, which are really important to know and treat patients. And I think that it's really important in making sure that our communities know that we have brought it upon ourselves to make sure that all surgeons out there are capable and have a governing body that makes sure that, we're safe and educated in everything that we need to be in.
I think you highlighted two things that I think is exactly on point. And as I've learned more about the American Board of Surgery and become more involved there, one is that the commitment to the public and making sure that we provide an assurance that surgeons are safe and well-trained. And the second is, the remarkable changes that have happened over time, as you alluded to, particularly around the pandemic, where going to virtual environments, I imagine that many of your colleagues and perhaps yourself have experienced some of those really remarkable alterations that have happened or that you're about to experience. So that is really quite remarkable what's happened. Another area that you kind of touched on in your article is with regards to another area that's changed quite a bit over the years, which is duty hours and the fact that there are duty hours regulations at all, right? At one point, there was really no sense of regulation. And now there are really clear guidelines to help ensure that there's kind of a standardized format in terms of duty hours and that process. Can you describe a little bit about what you learned and your thoughts about it?
As we all kind of know, back in the day, when duty hours weren't a thing, you were operating, taking care of patients all day, all night, and the next day again. Obviously, that occurred way before my time, but I've heard many stories of this happening. And a lot of people kind of have pros and cons in this debate of, well, residents are really getting less operative cases than we did back in the day. I know a lot of my attendings going through residency said they were graduating with like upwards of 3,000 cases. Now I think the average is probably around 900 to 1,100 cases, for residents. But making sure that we're all getting quality cases and also taking care of patients in a safe way is important. So reaching that balance is really important. The catalyst of a lot of this happened in New York in the 1980s with the Libby Zion case, with the IOM report following that discussing duty hours for residents and the fact that residents need to be supervised. That's important. Also recognizing that this is graded in terms of training. All residents aren't necessarily treated the same in terms of what year they are. And I think these are all kind of things that are important to look at and to realize. So going through all of that happened and having duty hours being so restricted, well, I shouldn't say so restricted, but, being restricted to the 80-hour work week after ACGME adopted that. And then surgeons recognizing that, training is different in different specialties. Certainly that's seen in the neurosurgery world where they never really had those strict work hour guidelines, and that there should be some flexibility in duty hours and how different programs can look at, how their structure of their program is and really change that to see how their residents would most benefit from different changes. So, with the first trial that examined the flexible work hours versus duty hour restrictions showed that there's really no difference in terms of patient care. And while there are some changes in the way how residents see their out of hospital time, a lot of residents did appreciate the continuity in care and their ability to perform cases in the flexible duty hour group. It's not a one fit all type of thing. So, there are going to be people who still prefer one way or the other, but I think it's really important to kind of have options and to allow programs to kind of see what fits best for their program, because it's going to be different everywhere. But the key is that we as a community of surgeons recognize that this doesn't fit everywhere in terms of the 80-hour work week. And some programs will benefit more, residents will benefit more one way versus another. And to know for a fact and to have data that backs you up and to say, well, this is still safe. It's, the first trial proved that it's non-inferior in terms of compared to duty hours. And that's important. And so, we kind of stuck up for ourselves and to see how is the best way to continue our future in training residents.
And I think the first trial and the current second trial, both are really great additions to the knowledge base that we have in surgery. I completely agree with you. Another area that you touched on was in a major area of advocacy. And in fact, every time I go up to the Hill, I kind of mention this issue because I think it is such a major issue that probably gets under emphasized, and it has to do with surgical workforce and how critical it is to ensure that we have an adequate surgical workforce in the future. Could you elaborate a little bit more on that topic that you covered?
Sure. So obviously, there's been a huge issue with workforce, not just within surgery and surgical subspecialties, but all specialties. And this has been known for years and years and years. Currently, we have the Resident Physician Shortage Act, which is being considered both in the Senate and the House, and that is looking to expand residency positions throughout the country to 14,000 residents, I believe, in 2029 in total. That really only is a drop in the bucket, essentially, because our shortages are going to be, some will predict up into 100,000 across all specialties of medicine. And especially looking at rural areas is really important, as there's only 8% of surgeons providing 20% of surgical care in these rural areas. So there's a huge deficit there. And opening up training programs in these areas that can provide access to surgical care, it's really important. And that's also going to help pull surgeons in to work there professionally and not just train there. it's really important, especially as other APP providers have their own residencies and they're being able to expand to provide treatment as well. We need to be able to do it in the same manner, and if not, more, depending on what the different supervising laws are in different areas. Those things are all changing. Certainly, there are things that only surgeons can provide, and there are issues within scope of practice that are currently being discussed on the Hill and really everywhere. And I think it's really important for us to be able to continue to advocate for ourselves and for our patients to get good surgical care from surgeons.
Absolutely. I think it's an incredibly important issue, and I completely agree with you. Though some work has been done, I think there's a lot that remains, and perhaps some of us are in more urban areas are a little bit insulated from this issue. But yes, you're exactly right. In rural areas of the United States, are those surgical deserts where there is no surgeon, and it really kind of affects communities as a whole, as well as I'm sure you know and are aware of, where without a surgeon in the community, and a hospital cannot survive, and the community sometimes is not able to survive without adequate health care nearby. All of this kind of goes to the point that, which is one of the major points of your article, which is about how we need to be educated about advocacy and health policy. And you pointed to a few different ways that can happen. And perhaps let's talk about kind of the most substantial type of education, which is with kind of formal education that happens in courses, graduate degrees, formal certificates, things of that nature. What kind of areas did you find where we can, for those who are interested and have the ability to take some time and really devote a year or two to really understanding this field, what opportunities are there for those individuals?
There really are a lot of opportunities. I think there are a lot of different universities across the country that have established programs to be able to provide this service to residents so they can actually go out into the community and learn what really is missing in terms of what they can provide. Because every different region is going to have issues that are specific for that region. So not all places are going to have the same deficits in terms of what their care is. And it's really hard to, kind of figure that out without learning a little bit about the community. I think that especially now that there's a lot of interest in having those extra years within your residency program to not just do training, but do some sort of research, whether that's clinical or basic science. I think that calling them professional years instead of doing research years is important, because I think that research isn't necessarily in the formal way that we think of it as basic science is not going to be something that's going to benefit each resident, but doing these other things and focusing on leadership, focusing on advocacy, focusing on your community is really important. And I think it's equally, if not at some points, more educational, depending on what your situation is. Obviously, the American College of Surgeons has a lot of different programs that you can access that are kind of mostly workshop type things, which are really great. But at the same time, that's a one-time point in the sand. And it's important to also be able to expand that to be more longitudinal so you can learn more and be more effective in the way that you can outreach to your community. There are definitely different professional degrees that you can also pursue that will focus on healthcare policy. There are different focuses on healthcare policy, whether it's, managerial, or if you're looking more to be involved in your hospital administration. And actually, a lot of programs have also created certificate type programs where it's kind of like a 1-3-week series of educational material that even if you're on a research year, you could easily go and take part in these programs to be able to learn more. Being technically good in surgery and being a good physician does not translate into being a good leader and being a good advocate. I think physicians have been given an inappropriate weight on your shoulder in terms of, going through all of residency. You come out knowing everything about medicine, or you come out, knowing exactly what you're supposed to be doing in terms of all aspects. But we don't. That's not how we're trained. So if we don't seek these education opportunities, then we're really going to be at a loss, and it's going to be more difficult for us to be able to really make an impact later on. So educating all the residents now is going to make it easier for them to be supportive of our community in the future.
You kind of alluded to your journey in becoming interested in advocacy kind of early on, even in your residency. I imagine that you had a mentor or someone that you looked up to who helped guide you into becoming more interested in advocacy. And kind of want to give you an opportunity to give a shout out to that person. So who kind of mentored you into being interested in advocacy?
I think really the reason why I got really involved in the American College of Surgeons was actually Patricia Turner. She came to do a grand rounds at Tulane when I was a second year resident, and just kind of listening to her speak. I mean, she's really an amazing person. after her talk, I went up to her and I asked her, how can I get involved? And immediately she sent me an email being like, these are the people you need to reach out to. This is who you need to talk to. So that's how I got involved. And being a part of the RAS committee within ACS, specifically the education committee, you just meet residents from across the country who are just as passionate as you about really getting involved. And it was just such a great experience. So it's hard for me to say like, oh, I have one mentor. Because I really don't. I just have a community of surgeons who really love the idea of helping other surgeons and being able to protect our profession and to protect our patients. I've been really involved in RAS, and I've met a lot of people through my different activities within the organization. And that's really what's prompted me to become so involved and to want to bring other people into our community and into the different committees of ACS to get more involved.
I have to admit that I'm not at all surprised that it started with Dr. Turner's talk. So knowing her, she is very inspirational and
yes.
a great leader. So, well, we've covered a lot of different topics, Dr. Ochoa. Is there something that you wanted to highlight that we haven't covered?
No, it's so easy to get involved and to reach out, especially, as a resident. There are 4 main committees within RAS: the education, the communication, membership, and advocacy committees that meet on a monthly basis where you can get involved. It's so easy to learn about just specific things on how you can be a better advocate as a surgeon and to improve the education within your residency training and bring that back to your own program and see how it fits. See how you can change any curricula to fit your program and to educate your fellow residents and attendings on all the things that are important about advocating for ourselves, for our own education, to improve our own education and improve the care that we give to our patients. Get involved, reach out to anybody within the ACS community. I can assure you that everyone will be very happy to help you in your path to success at your program. And we just really want to see the future surgeons grow to be leaders in surgery and leaders in medicine.
You've provided a lot of great tips, and so perhaps we'll conclude with this last one, which is for individuals who are watching this discussion, this conversation we're having, what's one thing that they could do today that you would suggest as kind of the first step?
I think one of the easiest things you can do, since everyone has access to the internet all the time, whether you're on your computer, your phone, Google Surgeon's Voice. It's the professional association for the ACS, and it lists all the different stances that ACS has taken in terms of different issues that are important for us as surgeons, whether it's prior authorization issues, surprise billing, Medicare cuts that are going to significantly affect a lot of surgeons across the country if something's not done about it, access to care, anything you can read about. There's information where you can find who your local representatives are so you can talk to them. There's pre-printed out letters and everything. All you need to do is put your information in and put in any other note that you would like to add. It's so easy, and it's a good way for you to learn about what are the important issues that we're trying to stand up for ourselves for, looking at that and talking to your own fellow residents and attendings at your institution to see what they think or see if they even knew that it was an issue to begin with.
Well, Dr. Ochoa, I very much enjoyed our conversation. Congratulations again on your article in the Bulletin, and thank you for taking some time to discuss it with us.
Yeah, thank you very much. I very much enjoyed talking to you as well.